You go ahead.
Sure, sir.
You are here.
Shall I start, sir?
So you will introduce
The
again give the
speakers?
concept and no the concept and everything, and today's topic is COPD, and then
Okay.
the three talks which are going to be there,
Hmm.
and the results will be declared by you, Deepak.
Yes, sir.
तेरे पास है
Questions
the three winners.
uh, I will ask them.
Okay.
So the winners we will announce in the last, na sir.
पिछले वाले जो हैं, अच्छा चलो वो
Last.
मैं बीच में कर दूंगा, मैं बीच में कर दूंगा विनर्स का, लेकिन
मैंने
पीजी
आपको
क्विज
वो
लाइव करने के लिए आई थिंक इनको वापस देना पड़ेगा.
हाँ.
तो ऋचा,
Also, sir, this Swapna wanted to give some intro to
QR
how do
code.
you do
Just the QR code and
pre-test and post-test.
yeah.
so I think Rucha तुम start करके then you tell them that now we are going to start with the quiz and how to go for the quiz. Sapna will explain you.
Swapna will.
And
Okay,
once
sir.
the quiz is over, then you take over and start the sessions one by one, 1, 2, 3, right?
Sure, sir. Okay, sir.
Okay. Countdown.
It's already we can go live, ma'am. We can start. Yeah.
Sure. Good afternoon, everyone. This is Dr. Richa from Respiratory Medicine, CMC Vellore. As a part of PACS, we are here again with the second module for PG Connect. The PG Connect program, as envisaged by Dr. Deepak Talwar and the PACS team, is actually meant for the specifically for the postgraduates who are going for exam, or for that matter, any year of postgraduates. We have come out with 8 modules of different, each module will be containing about different diseases, the details about the different diseases, starting from etiopathogenesis to the management, what is new and what a postgraduate student should know. This will help in making the diagnosis of the disease condition as well as the management of the condition much easier, and the way how the guidelines propose to do it. This is our second module where we are talking about how do we optimize the management of obstructive airway disease towards the personalized therapy. For today's session, we have 3 eminent speakers who are going to talk to you about the spectrum, etiopathogenesis, and clinical features of obstructive airway disease, which will be taken by Dr. Pranav Ish, who is Associate Professor at the Safdarjung Hospital. The second talk would be on the diagnostic evaluations and tests in obstructive airway disease, which will be taken by Dr. Kanishka Singh, who is the Senior Consultant at Pulmonary Critical Care and Sleep Medicine Metro Center for Respiratory Disease at Noida. And the last talk will be taken by Dr. Deepak Talwar, who will be talking about management of stable diseases as well as exacerbation. And he needs no introduction. Sir is Director and Chair at Metro Center for Respiratory Diseases, Noida. Now, even before we start that, we would be having pre-test quiz and a post-test quiz, which will be taken by Dr. Deepak Prajapat, again, who is a senior consultant at Metro Center for Respiratory Diseases, Noida. But having said that, I would hand over this session of the quiz before Deepak starts to Swapna, who is going to talk to you about how do we go through the things and what are the different prizes which will be available when you are participating actively. Over to you, Swapna.
Thank you, ma'am. Thank you so much. Good afternoon, everyone. So, those who have attended the module 1 must be well aware of how this entire thing works. But for those of you who are joining for the first time with us, we have a QR code. So we want to make this entire program very interactive and engaging. So we have this QR code where you have to enter, after scanning this, you have to enter your basic details, which is your email ID, mobile number, and then you can start using this platform. So I'll just give you a few minutes or a few seconds to scan the QR code, please. and please fill in the details that are required. This QR code is also available with our team members who are there at each of the centers. In case you're unable to scan from the screen, please reach out to them. Okay, so once you scan the QR code, you enter your mobile number, you enter your basic details, the email ID, and then you'll receive an OTP. And once you put in that OTP, for those who have already done this, I believe you won't need to do this again. But once the OTP is put, you can start actively engaging. So during these sessions, you can post any questions that come to your mind regarding that session. We'll pick up a few, most voted questions, and those will be answered by our faculties. You also have the option to upvote or downvote. So in case you feel that a particular question is important, you can upvote it, or if you feel that the other questions in line are more important, you can downvote it, and the most upvoted questions will be taken up and answered. You'll be getting points for each engagement, right from asking questions to upvoting and downvoting. uh, and also we have a pre-session quiz as well as a post-session quiz. And what's the most interesting part is that for the winners of the post-session quiz, the top three winners will receive exciting prizes. We already have the winners for the last session. Sir, would you like to give a
Yeah.
shout out to them? Yeah.
Okay. So first prize is to Dr. Sti Pranja Prusti, and it is Amazon vouchers for 10,000 rupees. Second prize is for Vamshi Gout Maimedi. The prize is Amazon vouchers for 5,000 rupees, and Sonali Swagitika Priyadashni, third prize, which is 5,000 rupees vouchers by Amazon. So all three winners, congratulations. And if you have won in one episode, it does not matter. You can still win the next one also. So keep doing it so that you get as much prizes as we are all giving in the 8 episodes. All the best to you.
Thank you, sir. And apart from these winners who will be winning each of the quiz in each of the modules, the top three overall winners also have grand prizes. Apart from the Amazon vouchers, Dr. Talwar sir is also giving them an opportunity to be a host at the next PAX annual meet, which will be happening in August this year, which is a huge opportunity considering the scale and the academic reach of PAX. So that's about the prizes. So these prizes will be calculated based on the number of right answers that you're giving in the quiz, the fastest, how quickly you're answering. Plus, there are points for upward, downward, and asking each question. So 10 points for asking question, 1 point for upward, downward, 10 points for every right answer in quiz, and 100 points for overall winner of the quiz. And we'll be calculating the cumulative points, and the final three winners will be based on the cumulative points that is being received. So if you all have logged in, if you haven't yet scanned the QR code, this is the QR code. Kindly scan it. And I think the pre-session quiz is live. You can just take it. So there is this tab over there which says take quiz. And I believe we can give around 5 minutes for all of you to take this quiz, and then we'll start the session. So please scan the QR code, fill in your details, put in the OTP, and you can see this tab of take quiz. So it's
Sapna, are the questions being seen on this or they have to be read?
they can see it on their mobile phone. And the final quiz, the post-session one, will be moderated by Dr.
Okay,
Prajapati.
okay. So let them answer this,
Yeah,
and I think we can give 5 minutes
5 minutes.
for 5 minutes for answering. There are 10 questions, and choose the most appropriate answer, which is according to you. And we are not telling you whether you will be getting prizes by just the pre-quiz or the post-quiz, as well as all the points which you are earning on the upward, downward, asking questions, and many things like that. So lots of points to be earned, and then only finally you will be able to get the prizes which are there. And of course, there are many prizes, and each episode will keep having more and more for postgraduates to be stimulated to answer the questions, learn the questions. Why was the question there? What was the why was the answer only one correct? All those things you need to discuss among yourselves. We encourage you to discuss this quiz questions among yourselves, even if not possible now, later on. I think in another 1 minute it is 3:15. So Richa can start. Is that okay, Sapna?
Yes, sir. Yes, sir. So if you can please ask them to scan the QR code. We have around 90 students who have scanned so far, and they're taking the quiz.
So all the postgraduates who have just joined, please scan the code and start answering the questions. That is the pre-quiz 10 questions with 4 multiple choices for each question. So please answer that. You can win handsome prizes. Even if we start the program, Sapna, I think they can continue to do that. Is that right?
Sir, am I audible,
Yeah.
ma'am? Yeah. So we can start now. I mean, they'll answer the quiz. Whoever is joining late, we can start.
Okay.
Sapna, you stop sharing. Um,
Ma'am, can I share my screen?
Yeah. It's a pleasure to invite Dr. Pranav Ish, our first speaker for today's module on obstructive airway disease. Dr. Pranav Ish is going to give you an overall introduction, talk about the spectrum and the etiopathogenesis and clinical features of OADs. Over to you, Dr. Pranav.
Thank you, ma'am. So I hope my screen is visible. I'm audible. At the outset, I would like to thank Deepak Talwar sir and Richa ma'am for this opportunity. So we'll be discussing about COPD. As I was told, we'll focus on COPD. So I'll focus on the spectrum, the etiopathogenesis and clinical features of COPD. Diagnosis and treatment will be discussed by subsequent speakers. I was asked to just put this QR code in case some student who has just joined can scan it. Now, COPD is something, please remember, which is very heterogeneous. The word is chronic obstructive pulmonary disease. So ideally, it is not one disease entity. It is kind of a group of heterogeneous lung disorders where you have chronic means long term and obstruction in the lung. Just very quickly, 1997, Gold had the first meeting. Before that, actually, COPD was looked with nihilistic attitude because there was not much success in treatment. People believed it is self-inflicted, mainly caused by smoking and other, I would say, vices. There was not much treatment option. So it would kind of be a label like a death sentence, and nobody was willing to treat or probably admit or even probably try to diagnose COPD patients. Then, of course, Gold started. We had WHO, NHLBI, and various other organizations came together. And every 5 years, we have a major revision, and every year we have an update. Now, in recent years, Gold has started releasing the next year's update in the month of November only in the World COPD Day. So the Gold 2026 guidelines were already released in the month of November 2025. We'll quickly go through what is new and what we should at least know as a resident when we are treating patients. So in the definition also, which is quite same over the last 2-3 years, they start with the word heterogeneous lung condition. So COPD is a heterogeneous lung condition, lots of phenotypes, lots of etiotypes, which we'll discuss. having chronic respiratory symptoms, and the common symptoms being dyspnea, cough, sputum, and exacerbations. So exacerbations are mentioned as symptoms only. Some patients can actually come with just recurrent exacerbations. This is due to abnormality of airway and or all alveoli. So these two words are important because they give you the pathobiology. Airway could be the airways in the form of bronchi, so bronchitis, or it could be just the distal peripheral airways like the bronchioles, hence the word bronchiolitis. So chronic bronchitis entity is included in COPD. Even bronchiolitis ideally comes under the purview of COPD. And or alveoli. So if you have an alveolar destruction simply in the form of emphysema, that also qualifies as COPD. That causes persistent. The word persistent is important. That is why we do a post bronchodilator FEV1 by VC ratio, and often progressive airflow obstruction. So the few words which I have highlighted are actually important not only for definition but also understanding COPD. Few words again which they mentioned. Early COPD means something which is biologically early, something which is like probably going on, maybe initially as pre-COPD or PRISM and will progress to COPD. Mild COPD is mild in terms of obstruction. So you will label this if you have an FEV1 more than 80%. Young COPD is an important word they've given in which the age group is 20 to 50. So no longer you can say asthma is a disease of the young and COPD is a disease of the elderly. You can have a young COPD also. Now, what would be the risk factors for this? So subnormal peak lung function. Supposing somebody is having IUGR, low birth weight, repeated childhood infections, maternal history of smoking during pregnancy. So all these factors would probably lead to underdeveloped lung, and the patient can develop a fixed obstruction even at the early age of 20. Pre-COPD is something which they've defined, something like pre-hypertension or pre-diabetes, where you have symptoms, respiratory symptoms, and or structural abnormality. Structural could be in the form of CT changes like emphysema, and or functional abnormalities. Functional could be like FEV1 is reduced or FBC is reduced. So if you have any of these three, you can label a patient as pre-COPD. Why the pre-COPD word came is now at least you'll follow up this patient. You will not ignore the patient. You will not ask him not to follow up. So you'll document patient is having cough, patient having exertional dyspnea, PFT at present normal, to be followed up, and you can put a label of pre-COPD. One subgroup of this is PRISM, which we have extensively heard in various conferences also. It is preserved ratio, but impaired spirometry. So many times it is debated why should we use a fixed ratio of 0.7. Many guidelines, ATS, ERS now recommend LLN values to be used, but gold guidelines maintain that to keep simplicity, we use a fixed ratio of 0.7. So they themselves say if you are using this 0.7 fixed ratio, you may have some patients who may not show a post bronchodilator obstruction. And hence, PRISM is something which again you will follow up. Some of them may develop COPD, some of them may turn out to be normal, and simply because of, let's say, some acute infection had those abnormalities at that time. Smokers, high BMI, low BMI, all these are risk factors eventually which lead to development of COPD in these patients. So this is, of course, the definition and the some terminologies given. Now, as per estimated prevalence, your global burden of diseases, GBD in 2019 and 2021, actually predicted that prevalence is only 2.6 or 2.5%. But multiple population-based studies and other sources, which are small studies done in various countries, have shown that this may be a gross underrepresentation and the prevalence may be as high as 10%, 10.3 or even 10.6%. Board guidelines themselves say what could be the reason for this. We really don't diagnose COPD. Patient factors are they underreport their symptoms. They adapt to their breathlessness. They adapt to their work. They keep sitting, so they say they are not breathless. Healthcare, of course, we do not have spirometry everywhere. I asked for some investigation from a patient, he'll get thousands of blood tests done, but spirometry is something which patients and labs and various, I would say, healthcare services still find it difficult to offer. Healthcare provider related factors, which is again important. COPD as an entity, unfortunately, is known to less people, even in doctors. Asthma is probably a little more known, but COPD is something which we don't know, and many physicians still do not know how to interpret a spirometry. So probably it's our job in that way to at least help our colleagues also timely diagnose. From the epidemiology point of view, globally, COPD is the third leading cause of death. And even global data shows that half of these may actually be underdiagnosed. But what is the situation in India? So this is the data from India in 2009. If you see, ischemic heart disease and diarrhea were the first two causes of death. Diarrhea gradually slipped to fourth, stroke came up, and COPD moved from fourth to second. So this was in the year 2019, where at least in India, COPD became the second most common cause of death. Now, of course, COPD and stroke keep alternating. So COPD has again slipped back to third, similar to the global proportions. But India being a huge, huge country, the contribution of COPD to both morbidity and mortality is very, very high. And being a chronic illness, I would say the morbidity is something which is again often ignored. So out of the chronic respiratory disease burden in India, COPD actually accounts for half of them, 50% of the disease burden and 70% of the daily loss. Now, some words which again have been given in the guidelines are etiotype. The word etiotypes means etiology being phenotyped. So it could be a COPD-G, which is genetically, probably due to some alpha-1 antitrypsin deficiency, and D, which is developmental. So the young COPD, which I said, could belong to these categories. COPD-C, something which always traditionally has been considered as the most common cause of COPD, both active smoking, passive smoking, environmental smoking, vaping, e-cigarette, cannabis. But multiple studies in India done by South India, even West India, even in our hospital, we did a study. We found COPD-C is probably not the most common phenotype. So what was again then seen? COPD-P is probably the most common phenotype. And then it was argued that biomass fuel exposure is something which is very common in India. But let me tell you, practically, biomass fuel exposure is gradually declining. More and more rural population also is now not being exposed to biomass fuel. So maybe if you have a patient in 60s or 70s, 20, 30 year back, they might have had exposure to biomass fuel smoke, not have had chimneys, not have had separate kitchens. But nowadays, this is also decreasing. But what is more worrisome is the P part, that is the pollution part of it. The ambient air pollution and various pollutants are now coming more and more into the limelight, and they are probably the most common phenotype which we see in our population. So a lot of patients I see, they are COPD, fixed obstruction, respiratory symptoms, non-smoker, probably related to pollution. COPD-I is also something which has often been ignored. There was a lot of debate on what to call post-TB sequelae, post-TB lung disease, post-TB obstructive airway disease, maybe post-TB bronchial hyperesthmia. So the best and easiest word is if you have a post-TB sequelae patient having fixed obstruction, COPD-I could be an easy terminology because this will help you decide treatment. You have COPD guidelines to treat such patients. And TB-associated COPD, HIV-associated COPD is coming under this gambit of COPD-I. COPD also solves the issue of asthma COPD overlap. If you have a patient who has childhood asthma and now has developed a fixed obstruction, you can label that as COPD-A. Treat as per COPD guidelines, but then you must ensure you should continue your ICS with that. And still, you may have a lot of patients where you do not know the cause, you can label them as COPD-U. So this is something very important. And in Indian context, I think the PIAU, these four etiotypes are probably even more important. So just to show you, in India, we have lots of cigarette BD smokers, BD being probably more harmful, going more up to the periphery of the airway, increasing the risk of adenocarcinoma also, and even a shorter exposure can lead to COPD. Then all those household pollutants which I talked about gradually on the decline. We now have separate kitchens, separate chimneys, and even the gas stoves. Some occupations which will always be at risk, coal mining, stone cutting, but ambient air pollution is something which we ignore. The pollution not only comes from the kitchen or the work, but your probably agriculture, your vehicles, your construction sites, even some religious activities, and of course, all those risk factors like old tuberculosis. So these are probably the more important risk factors in the Indian context. This is an image I borrowed from a thoracic surgeon in India who says that probably used to see healthy pink lungs before and black lungs in smokers. But now in non-smoker young patients also, he has started seeing black lungs when he operates on them. So this is something to worry about. There is practically no non-smoker now left, at least in the metropolitan cities. Does pollution cause COPD? Well, it directly goes to the small airway, affects the epithelium. The epithelium is destroyed. And once the epithelium is destroyed, all the cascades of inflammation, permanent damage, fibrosis, and irreversible repair starts. A few words about post-TB COPD or COPD-I. Well, the symptoms are quite similar. So your dyspnea, cough will be quite similar. Something extra you'll have is probably you have some evidence of parenchymal damage also, some cavitation, some bronchiectasis, concomitant. So you may have hemoptysis, you may have a lot of radiographic changes, you may have large airway involvement also. And unfortunately, this occurs in the younger and the socioeconomically active population of India. Symptoms, as per the guidelines also, common symptoms are dyspnea, which progresses with time, worsens with exercise, and most important, persistent. This is the most important word. Patients may have recurrent wheeze, chronic cough, which is usually productive because it's airway related, but it can be non-productive also. And this is why this is important. It could be just peripheral airways, which is not, as I told you about bronchiolitis or emphysema, where you may not have a lot of sputum. And all the risk factors which I've discussed with you should be taken in the history when you're evaluating such a patient. The differential diagnosis listed mostly is asthma, where you have variable obstruction, variable symptoms, some history of atopy, some family history. Important in the elderly age group could be your congestive heart failure. You must consider acute myocardial infarction or an ischemic cardiomyopathy where you have pulmonary edema, which is giving rise to dyspnea. Bronchiectasis can be a differential, but can be a concomitant entity also. It has been seen that 10 to 20% of COPD do have concomitant bronchiectasis, at least in India. Bronchiectasis often presents with recurrent infections and large volume of purulent sputum. Tuberculosis will always remain a differential for all pulmonary diseases, which can again be one of the cause of worsening of this COPD also. In Indian context, if you have dyspnea, you may also think of anemia, you may also think of lung cancer and various other post-TB sequelae also. The most important thing to remember, which I also agree, the World COPD Day in 2026, so the theme they have released in 2025 for 2026 is short of breath, think COPD. So if you have a patient who presents with dyspnea, at least keep COPD as one differential. This will help you further evaluate the patient and at least arrive at an early diagnosis. Thank you.
Thank you, Pranav, for that comprehensive overview about the COPD. I would encourage all the participants, especially the postgraduates, if you could please post the questions you have. We wanted to take it after each talk, and later, if anything is remaining, we can take it at the end of the thing. So we'll wait for a few seconds and see if we are getting the questions on your talk, Pranav.
I mean, it was mostly introduction, so I think
I
spirometry
know.
and treatment will be very
Yeah.
important for
But
the
I
risk.
think it is very, very alarming to see the way COPD has come up to the second cause of mortality in our country. So it's important. And as you rightly said, it is not smoking related COPD, which is more common in India. It is more of COPD-I and COPD-P pollution one. So, Swapna, do we have any questions for Dr. Pranav?
Maybe if we get it towards the end, we can take it up.
Sure, ma'am.
Okay, sure.
Sure, ma'am.
So thank you, Pranav, and
Thank
we
you,
want
ma'am.
you to be here to answer any questions in the last. It's my pleasure to invite Dr. Kanishka Kumar, who is the Senior Consultant at MCRD Noida. And Dr. Kanishka will be talking about the diagnostic evaluation or the working up of a patient with COPD, including the test which is required. Over to you, Kanishka.
Thank you, ma'am. Thank you for the introduction. And I think Dr. Pranav already, took a lot of burden from my presentation, and I'll be very quick with the rest of the things which is not discussed in the previous presentation. So he already, gave the highlight about what COPD is, heterogeneous disease, the symptoms, and which leads to, cause persistent and progressive airflow obstruction. Okay. So these are the terminologies which was already discussed: early COPD, mild, young COPD, pre-COPD. So this will be a revision for all of you. This is the prism which we talked about in the previous lecture. Now I'll be talking about the workup which is done for a proper COPD patients when you suspect a COPD patient coming to your OPD or IPD. You will be taking the history, of course, exposure and occupational history, and the symptoms which itself is mentioned in the definition, like cough, shortness of breath, and we'll be talking about the history of smoking as well. And then when it comes to the evaluation after a proper history, you get an idea that where are you heading, and then you'll be doing the spirometry. We'll be talking about the spirometry, how to interpret later on. Then you do ABG as well, because ABG is done for multiple reasons, but in COPD, for giving a patient long-term oxygen therapy, you need to check the PaO2. If that is less than 55, then you can plan for long-term oxygen therapy in such patients. Serum sodium potassium sometimes needs to be checked, and that comes in the ABG also. Not very reliable, but yes. Alpha-1 antitrypsin deficiency is something which needs to be checked whenever there is a suspected COPD patients with deranged liver enzymes, and you're suspecting that there might be a genetic involvement. So we'll be labeling it in COPD G. For the treatment, and genetic study needs to be done in such suspected patients of alpha-1 antitrypsin deficiency. You need to rule out cardiac causes of COPD. So to rule out the cardiac causes, we'll have to do NT-proBNP and to rule out the heart failure, and whether the breathlessness is because of the cardiac condition or because of the lung condition. And you'll be doing the X-ray, chest X-ray. I'll be showing one of the X-rays later on. So in the chest X-ray, there will be flattening of diaphragm. There will be increase in the retrosternal spaces. There might be a lot of lucency, which will be highlighting whether the patient is having bullous lung disease or not. CT is not very much helpful in the COPD patients, but yes, can be done sometimes. But yes, X-ray needs to be done, and needs to be understood what kind of hyperinflation the patient is having or not. Echo is also done to rule out heart failure, but can also be done to understand whether the patient is having pulmonary hypertension or not, because COPD can lead to pulmonary hypertension. And 6-minute walk test is something which is there in the board index, which will be giving us a hint about whether the patient's condition, whether it is improving or not, or the prognosis of the patient later on. You must say that 6-minute walk test will be giving us an idea. We'll be talking about that also. And in the blood, there will be CBC, which will be helping us to know about the eosinophils and hematocrit and right heart catheterization, sometimes done to understand the pulmonary artery hypertension. So this was the overall gist of the workup which needs to be done in a COPD patient. So it was discussed before also, the etiotype COPD-P. So you need to talk about and ask the patients about, the household biomass, smoke, the occupational history, and the ambient air pollution, if there is any or not. Secondhand air pollution can also be very important. So this is a part of the history. So just I mentioned it. Smoking, I discussed that we need to ask about the smoking related history, because after that there will be oxidative stress, which leads to chronic epithelial injury, and due to the imbalance of protease and anti-protease, the patient leads to the development of COPD later on. But yes, there are treatment for that. Of course, smoking cessation is the first, and later on pharmacological and behavioral therapy needs to be given to such patients. Of course, ma'am was saying about tuberculosis just a couple of moments ago. We need to understand and take history of tuberculosis, because in these kind of patients, we have to avoid the indiscriminate use of inhaled corticosteroid that can lead to infection risk, increase in infection. So we have to control ICS in such patients, and that will be done by X-ray and a proper history taking. Now, I talked about the alpha-1 antitrypsin deficiency. We have to think about the COPD gene, and if you're suspecting any liver diseases, then definitely you do that test. If there is a deficiency, the levels are below, then of course you'd go for genetic study. And of course, the treatment still not available in India. It's very costly in other countries as well, but we need to diagnose that such patients for alpha-1 antitrypsin deficiency as well. So this is one of the most important slides for the postgraduate students to understand how to interpret a PFT. So first step is to check for FEV1 by FVC. If that is normal, you check FVC. If that is normal, then the patient is normal. Then if you check if that is reduced in step 2, then you can label the patient as having restrictive lung disease. If the FEV1 is reduced, then there is an obstructive lung disease. But in step 3, you will be checking FEV1 if you have already checked the FVC, and if you have checked FEV1, then you check FVC. If either of them is reduced, then the patient is having a mixed obstructive and restrictive defect. But labeling any patient as obstructive or restrictive lung disease, especially, you need to assess the TLC. So this is the proper algorithm. If you have the TLC as well as the DLCO, then you will be able to diagnose or classify the patient in the in the different diseases which you're suspecting that is causing breathlessness, like emphysema, chronic bronchitis, asthma, or ILD, or any neuromuscular disease or pulmonary vascular disease. So this is the algorithm which is there. You can take a screenshot or maybe a photo of it. So according to the GOLD, what's the use of this FEV1 by FVC? As I told, COPD, obstructive lung disease. So FEV1, if reduced less than 0.7, you measure the post-bronchodilator FEV1 by FVC. If that is also reduced, then the COPD is confirmed. If that post-bronchodilator response is more than 0.7, according to GOLD, then you have to follow the response and needs follow-up and repeat assessment of such kind of patients. So according to the FEV1 criteria, the GOLD has given different severity of obstruction. The GOLD one is mild, that which is FEV1 more than 80% predicted. A moderate is between 50 to 80, severe 30 to 50%, and very severe less than 30%. Now you have the GOLD, in the severity classification with you. You have the history with you, and then you have to ask the patient about the breathlessness. Then you classify that breathlessness with the MMRC scale, and exacerbation history you have to take, and then you classify according to this table, which you can see on your right hand side corner. There are three classification: A, B, and E. You can put the patient in such classification after labeling A, B, and E according to the history and according to the spirometry reports. So which also includes a CAT score less than 10 or more than 10, if you can see below the A and B. So what is CAT score? This is a simple questionnaire which is there. And normally healthy people don't have a value more than 25, and unhealthy people will not have a value less than 25. Total score is 40. So you have to ask the patient, for example, I never cough, from marking from 0 to 5, and then you can label and calculate the CAT score. That will be helpful in labeling the patient as A, B, or E. Now, another role which has come and recently, being developed, 70 years has gone for, impulse oscillometry. But yes, to understand a small airway disease, you need to do impulse oscillometry alongside spirometry to understand the mechanics of the lungs in a better situation. So you just tell the patient to breathe normally and in the tidal volume, and the sound waves goes through the machine into the lungs, and according to that, the impedance is calculated. So what's the impedance? Impedance is the measure of resistance and reactance. So accordingly, we come to know whether the patient is having a small airway disease or not. It's very helpful in asthma to rule out, because it's a treatable trait. So before labeling a patient as severe asthma, we have to treat the small airway disease in such patients. So how do we understand what is impulse oscillometry? I'll be very quick. So just like the red light has a longer wavelength, but it travels very far. So similarly, more wavelength and less frequency waves travel far, and the shorter the wavelength, more the frequency, that will be traveling less distance. So we give a lot of variable frequencies in the airways when the patient is breathing in the tidal volume, and you can see that up from 10 to 23 there are small airways classification, and up to 7 there are larger airways. So if the more frequency, like 20 hertz, we give the 5 to 20 hertz frequency. So 20 hertz will not be traveling further, because more frequency, the larger the frequency, it will travel shorter distance. So that goes up to seventh level of the generation of trachea, and then airways, sorry, and then 5 hertz will be going deeper into the smaller airways. So when we subtract both of these resistance and at such frequencies, you will be able to understand that you get a small airway disease or not, and you will be getting the resistance, that is R5 minus R20, which will be helpful in the COPD patients as well. So this is one of the same patient doing the spirometry as well as impulse oscillometry. So you can see the Z5 is 206. Normally we can take it around 140, which is increased, and the resistance is also 191 at 5 hertz, and at 20 hertz it's normal, which is 133. So if you take 140 around normal, then of course 191 minus 133 will be significant, and this patient will be having a small airway disease. So this is for an example. You can understand that the small airway disease needs to be ruled out, because COPD group have higher R5 values, elevated R20, and of course greater R5 minus R20, and X will be the reactants, which will be more negative in COPD patients group. And of course, AX, which is the triangular area when we plot the graph, and that helps us to understand whether the patient's lung is stiff or not, or how much stiffness is there according to the values. So in COPD, it's also very important to understand the role of impulse oscillometry. Now we come to the 6-minute walk test. It's a very simple test. You ask the patient to walk, as far as possible in a, for 6 minutes in a flat corridor, and then you calculate the distance. You have to, normally use the normal encouragement words. Patient should be, well rested at that point of time. The clothes should be, not very loose, not very tight, and you don't have to tell them to rush, but yes, walk at their own pace. But yes, they don't have to stop. Normally, the values are 400 to 700 meters. But why are we talking about 6-minute walk test? Because it's in board index. When you see there is a area of one column for 6-minute walk test, and the use of 6-minute walk test is to predict the mortality of such patients. So in the follow-up also, and when the patient comes to you for the first time, you need to do a 6-minute walk test in such patients. Now, there is a subtype which is eosinophilic. I told that we have to do a CBC also to understand whether the patient is having higher eosinophils or not. So recently, after triple therapy, LAMA, and ICS, if the blood eosinophil counts more than 300, then you can give the patient biologic therapy. Of course, not available in India, but yes, 2 biologic therapy has been approved, which is dupilumab and mepolizumab. So I'll be talking shortly about the dupilumab. It's a dual inhibitor for IL-4 and IL-13. There are 2 trials, Boreas and Notus trial, which showed significant reduction in the exacerbation, which is 30 and 34%. So this is important for the postgraduate students to understand the dupilumab trials. And the dose is 300 milligram, which is given every 2 weeks. Now, the other biological which is also approved is mepolizumab. The 3 trials are MENTI trial, METRIX, and METRIO. So we have 2 biologicals for COPD as well, and that's why the role of eosinophils is very important. Now I'll be summarizing it. So we have COPD etiology as discussed in the previous lecture, and so we have to take the proper history and the exposure history, the smoking history, the tuberculosis history, whether the patient is having asthma or not, and of course after all the evaluation, most probably the patient won't go in COPD of unknown cause, and you'll be able to find out the cause. X-ray and CT is done, of course, to rule out, this lung disease or bronchiectasis or other abnormalities which is there in the lungs, but not usually recommended. But in X-ray, you can see the flattening of diaphragm, the increase in retrosternal spaces, and hyperlucent X-rays. So that's all, and this is the whole summary. Symptoms, risk factor, and comorbidities also have to be ruled out. Thank you.
Thank you, Kanishk, for providing us the insight on how do we diagnose the patients with COPD, including the basics test, the spirometry, which is very, very essential. If you don't have anything, at least try to have some handheld spirometer, and you can get at least the values of FE1, FVC, and can make a diagnosis. And then going up to impulse oscillometry, which is something turning out to diagnose early COPD patients as well. We do have few questions, but I think we'll take it in the last now. And it's my honor to invite Deepak sir for talking about, after you know about what is COPD, after you diagnose COPD, how do you manage the COPD? So sir will be taking on how do we manage the patients with a stable COPD as well as when they are in exacerbation. Over to you, sir.
Thank you very much, Richa. And can I share the screen? Okay. Is it visible?
Yes, sir.
Okay, fine. So I think I was listening to the last 2 lectures, and they have gone very well. Richa, you have been able to manage the time today very, very aptly as well as appropriately. So I think our main concern was that the episode last time when we did went little overboard. So we are trying to minimize this thing as well as keeping the content and other things in position. So my job is to talk about COPD management, and we know that patients of COPD are suffering from symptoms and exacerbations. So basically the treatment as per the goal 2026 remains the same, that you need to reduce the symptoms and reduce the future risk of this patient. And the future risk is of disease progression, exacerbations, and future risk of early death. So we need to overall improve not only the quality of life of the patient, but also the quantity of the life of the patient. So, in a nutshell, when we treat a patient of COPD, our idea is to keep them stable, keep them active, and prevent the periodic worsenings or what we call as exacerbations. And now Gold in 2026 also recommends that you need to really do a personalized risk-based approach. And Pranav very rightly said, there are high risk group of people and they need to be prioritized when it comes to controlling their disease. And the amount of medication, the choice of medication will depend upon how high is their risk to worsen COPD early, more frequently, and ultimately leading to reduction in life. Now, when we talk about the treatment of COPD, the most important two things are, is the patient already on some treatment or the patient is not on any treatment? So a patient who's not been on any treatment is a naive patient. And in the naive patient, we decide the treatment depending upon two verticals. One vertical stands on patient's symptoms, which is again a very important aspect because patient is suffering from them and they are dyspnea and cough. And dyspnea being the most important symptom for which the patient would report to us, we classify this either into MMRC or CAT scores. And in that case, when we use MMRC, which is very quick to use in our clinic, postgraduates need to remember this, that you have to ask one simple question to the patient, that do you feel breathless when you actually walk at the pace and the age of an individual of same as yours? So that means if you have a peer, a person who's a friend of you, and both of you walk and you find that this person is able to walk and you are not able to keep pace, that is MMRC2. And MMRC2 is very important to identify because it drives these patients into two groups, group A and group B. And this is primarily because the patients are more symptomatic in group B and less symptomatic in group A. And group A patients can get away with a single inhaler, long-acting inhaler, bronchodilator. But on the other hand, if the patients have got lot many symptoms or lot more severe symptoms, they will require a combination of bronchodilators, that is LABA and LAMA. The second vertical is exacerbations. And here there is a very important change which has come in 2026. Even one moderate to severe exacerbation reported in last 1 year immediately takes this patients to group E. So any moderate to severe exacerbation is pushing them into a different category, which is called group E or exacerbator group, whichever way you want to remember. And here you not only are trying to put them onto dual bronchodilator upfront, but also you are trying to phenoendotype them by looking at their eosinophils. And if the eosinophils are more than or equal to 300, then the inhaled corticosteroid as an add-on for a triple therapy is indicated. So the question here is for us to remember, everybody, that one moderate to severe exacerbation. What is a severe exacerbation? Severe exacerbation is the one which is treated with oral corticosteroids and add on other kind of medications or admission into the hospital. However, a moderate exacerbation requires the antibiotics plus minus steroids and maybe the one which has been treated at home or treated in the hospital but in the wards. So any moderate to severe exacerbation in the past 1 year puts the patient straight into group E. Previously there used to be two moderate or one severe exacerbation. Now it is only one moderate or one severe exacerbation. So that's the change which we need to remember. The second thing is that what is the role of blood eosinophils? I think Kanishka has already taken this very well, that your blood eosinophil count of 300 or more than 300 is actually favors the use of inhaled corticosteroids. But if you have one moderate exacerbation, even when their blood eosinophils are between 100 to 300, then also the inhaled corticosteroids are indicated. But if the patient develops repeated pneumonias with COPD, or blood eosinophil count is less than 100, or there is any history of mycobacterial infection like tuberculosis in the past, ICS is not recommended. So coming to bronchodilators as well as inhaled corticosteroids, which is the mainstay of therapy for COPD. So the mainstay will be dual bronchodilator, which is LABA and LABA, and of course add on ICS when this is dictated by either blood eosinophils or by the exacerbation with the aim to reduce the further exacerbations. So we have various inhaled corticosteroids, budesonide, fluticasone, and they all are anti-inflammatory, and we know that they reduce the inflammatory cells, particularly eosinophils. And that's why we are looking at blood eosinophil count to initiate inhaled corticosteroids in this group of patients. Then we have two bronchodilators, and the ones which are used for management of stable COPD patients are long-acting. So LAMA and LABA. In the LAMA group, antimuscarinic long-acting drugs, we have tiotropium, glycopyrronium, and umeclidine. They blocks the release of acetylcholine, and of course they remove the bronchoconstriction, leading to airways becoming more open and allowing the easy air going in and out. The second important point in LAMAs are that they regulate the production and clearance of mucus. So mucus is an issue in patients who have COPD, much more those who have got bronchitic type of COPD, which is again one of the phenoendotypes. And in them, it is very difficult for the mucus to come out from the airways, because airways are number one narrowed, and two, by retaining the mucus there for a longer period of time, it becomes very thick and viscid. So it's very difficult, and patients find it that they need to cough and cough a lot before they can discharge this mucus orally. And then the third group of drugs used, inhaled drugs used in COPD are LABAs. And these are long-acting beta-2 agonists, formoterol, salmeterol, vilanterol, and indacaterol. A couple of them are available. They bind to beta-2 adrenergic receptors and upregulates production of cyclic AMP. And this will lead to smooth muscle relaxation of the ones which are surrounding the airways, particularly bronchioles, which are these small airways which are very significantly involved with COPD patients. You have seen that you can pick up the diagnosis early with the use of oscillometry techniques in these patients. And also to some extent, LABAs also help in reducing the mucus hypersecretion. So the emphasis in Goal 2026 is to early initiation of triple therapy in order to reduce the disease progression in the right COPD group of patients. And this study tried to look into it, the data, which showed that there was a significant reduction in average annual exacerbation rates in patients on triple therapy vis-a-vis dual therapy. And that is why I think they have moved this needle of exacerbation frequency and severity to just one moderate exacerbation or severe exacerbation, where you need to initiate inhaled corticosteroid in addition to combination of LAMA and LAMAs. And you can see that earlier you put them on, lesser are the number of exacerbations. So you can see that those who are under the age of 40 show much better response to the triple therapy in considered to those who are above 65 years of age. The major reason for this is, if you are quickly able to control exacerbations, their number and severity, less lung damage happens in these patients and less future risk of exacerbation exists there. After you have decided that which drugs you are going to use, whether 1, 2, or 3 in your patient of COPD, the most important thing is to choose the right device for the patient. We have two widely used devices in our practice. One is PMDI, which is pressurized meter dose inhaler, and the second is a dry powder inhaler. These are both devices which require a lot of things to be done correctly for the drug to be released from the device and patient to be inhaling it directly and reaching into that part of the lung where it needs it, which is terminal airways and small airways. So PMDI, when it is to be used, remember that it requires 9 steps to go right for the adequate delivery of the aerosol into the lungs where we need to target the COPD airways. When we use the dry powder inhalers, it looks very simple, but it is not that simple because it also requires 8 steps to be correct, where the drug delivered from the device needs to reach our airways. So the important thing is look at the patient, their beliefs, their satisfactions, their current devices they are using, previous devices they have used, and their preferences need to be assessed and considered in making a mutual decision to decide which device is going to be not only good for the patient but also acceptable to the patient. A good device according to us, which is going to be the best for the patient, may not be the best because if he does not like it, he will not be able to use it. We should not switch the devices too frequently, and there should be a clinical justification as to why we are doing it, because we have broadly only 2-3 types of devices available. When we choose the device, we must always remember that whether the patient's strength is good, like elderly people, neurologically impaired people, people who have cognitive disorders, as well as dexterity issues related to management of the device with the hand, will find it definitely very difficult to use some types of devices. We need to keep in mind. Very importantly, dry powder inhalers are mostly good for the patients who can have a very forceful inspiration, because it requires a considerable amount of peak inspiratory flow rate. So if the patient is thin, fragile, weak, emaciated, he will not be able to use this. Meter dose inhalers does not require so much of power to suck the aerosol, but definitely the triggering and the inhalation process has to be in sync, and that requires a hand-mouth coordination very accurately for the patient, which again many patients may not be able to do. So you need to look at your patient as well as their choices before you choose whether I give PMDI or we go a dry powder inhaler, or sometimes even we have to go for nebulizers. Of course, many other things like maintenance of the device, cleaning of the device, all has to be told to the patient. And any inhaler which is to be given, patient must be trained on it. Remember, this is a naive patient, so they must be trained because they have not used the inhaler. And once you are satisfied that the patient will be able to use it, then only you will be comfortable in leaving him with that device to use at home, where he will be able to use it adequately. So we have meter dose inhaler, dry powder inhaler, nebulizers, and also breath actuated inhalers. So there are lots of them which are available, but every inhaler, whatever the device you use, requires an adequate, appropriate technique, and that needs to be taught to the patient not only once but repeatedly, because it is already reported that some patients who will do 1 or 2 steps wrong in the first visit will do those 1 and 2 steps right in the next visit, but will do maybe 6 or 7 numbers wrong. So what it means is you need not commit the same error in the technique. In the subsequent visits, you will find that he might be doing some other, or he or she might be doing some other errors. So this is a process which is ongoing, must happen on every visit to check for the technique of the patients. What about those patients who are already on treatment? So those patients who are already on treatment and doing good, reasonably good, and are comfortable, we don't need to actually change their treatment unless and until they are on LABA ICS, which I'll take later. But if they are not doing good and they continue to suffer and continue to have a poor control of COPD, then we go on to the next step to find out what is troubling them more. Is it their breathlessness or is it their exacerbation? If it is breathlessness, then obviously we have one bronchodilator, long acting, we add the second one. So we make it a single long acting bronchodilator to dual long acting bronchodilator. But very important is that any failure to respond with whatever drugs we have given we need to keep in mind that inhaler technique and adherence are very important issues and should go deeply into it before deciding that 2 drugs or 1 drug is not enough and we need to change our strategy for that. And obviously other things to add on will be non-pharmacological therapies, including the rehabilitation, exercise, building, and things like that, which will come later. On the other hand, if the patient continues to exacerbate, moderate or severe exacerbations despite being on bronchodilators like LABA or LAMA. So if they are on one, the obvious choice is to switch on to two. But if their baseline eosinophil counts are more than 300 or equal to 300, then they should be immediately switched to triple therapy, which is the LABA, LAMA, and the ICS. Those patients who continue to suffer on these drugs like LABA, LAMA, do they have any other option for them, or those even for LABA, LAMA, ICS people? If they continue to have exacerbations, we have two more choices: roflumilast as well as azithromycin. But already discussed by Kanishke's biological therapies, and now we have dupilumab as well as mepolizumab, both approved. We don't have dupilumab in our country, but mepolizumab is available. What happens if the patients are on ICS LABA and if they are uncontrolled? So these are the patients, if they have no exacerbation history, then we consider them shifting to dual bronchodilator, that is LABA, LAMA. If they are having exacerbations, we need to check their eosinophil count, and if the eosinophil count on therapy are more than or equal to 100, then we switch on to the triple therapy. But if they have the blood eosinophil count less than 100, we shift them to dual bronchodilator therapy instead of ICS LABA to LABA, LAMA. Then there are non-pharmacological therapies. So non-pharmacological therapy is very important related to taking care of the etiological factors, and smoking cessation is very important, but it will also mean try to separate the patient from the exposures which are related to his occupation or his domestic environment or related to pollution as such which happens in the air. So taking care of the exposure factors which are making the COPD worse is the most important non-pharmacological treatment, and smoking cessation is a part of it. Beyond that, it is improving their physical activity. So you tell them to be more physically active, participate in exercise activities, and of course those patients who are symptomatic in B and E group will require a formal pulmonary rehabilitation enrollment as well as participating in rehabilitation programs. But very important to remember is that these patients should all be prevented from future infections which can precipitate exacerbations. So vaccination, influenza vaccination universally for all COPD patients, pneumococcal vaccination for all COPD patients, pertussis vaccine for patients who are above the age of 65 years yearly. Every 10 years, 1 pertussis shot is to be given, shingles 2 shots to be given, and RSV vaccination which has been recently added to it. So the self-management plan for taking care of the patients who continue to have dyspnea or exacerbation is very important. Their education, and to tell them how to avoid getting into the situations which are going to make their dyspnea or exacerbations worse. Moving on to the next is that exacerbations. Now, what do we do when the patient comes to us in exacerbations? So each COPD exacerbation leads to decrease in lung functions, decrease in their physical activity, plays a significant role in depressing their mental health, decrease their quality of life, and thereby putting them into spiral of exacerbations where one exacerbation leads to another exacerbation and patient goes down this spiral to something which translates into higher mortality in this group of patients. So we really need to break that exacerbation cycle, improve their health status, and try to maintain their good lung functions without any functional decline. Now, this is a new concept which is coming about, disease stability in COPD patients. So how do we go about disease stability? So if we are able to maintain them for 12 months where they don't get exacerbations, there is no symptom worsening, they are almost the same as they were before, and they have a stable lung functions where there's no decline in FEV1. So if we consider all these things, then we are calling them now that COPD is stable. So this is a new goal post for COPD patients, that we try to treat them so effectively that we make them stable And that is the definition of stability at present, which has been given by Professor Dev Singh. And if you want to listen to his lecture, again, a video is available for disease stability by COPD in COPD patients by Professor Dev Singh. Coming to exacerbations. Now, exacerbations is a big problem. So you can see that there is a huge burden as far as it comes to exacerbations. So exacerbations has got a very significant uh, cost on hospitalizations as well as faster decline in lung functions, and also to the extent that when we talk about it, there is an increased mortality to it. So all over India, if you find that ICU admissions have got a significant number of patients of COPD with acute exacerbations, and when they get admitted, they don't come with only COPD or exacerbation, they come with multiple comorbidities, which includes diabetes, hypertension, ischemic heart disease, CVAs, as well as thyroid disorders. Moving on to this, that the patient almost requires 4 to 5 days stay in the ICU, which itself is a very, very difficult situation, considering that it is going to cost a lot of money either to the person himself or to the exchequer or to the government. And every exacerbation carries a mortality, and they continue to have a high mortality even after 2 years of their exacerbation in comparison to a COPD patient who has no exacerbation in the past year. So looking at this, the most important thing is to decrease the exacerbations in COPD patients in India, because in India almost 80% of COPD patients are in frequent exacerbator groups, because perhaps they are the ones who only come to us when they are sick, and they are sick to such an extent that it is already an exacerbation. What can actually reduce the frequency of COPD exacerbation? So if you look at it, we know drugs. So we know LABAs and LABA-LAMAs do this job of decreasing the exacerbations. Corticosteroids in specific group of patients, the exacerbations are reduced. That is when they have high blood eosinophils. Roflumilast, dupilumab, and mepolizumab reduce exacerbations. You must have heard that dupilumab reduces exacerbations by 30%, as Kanishk has already said, and about 25% by mepolizumab. Vaccines and long-term macrolides like azithromycin given 250 to 500 milligrams 3 times a week also reduces the infective exacerbations. Mucoregulators like N-acetylcysteine, carbocysteine, erdocysteine are also now being reported to be one of the strategy to reduce the exacerbations. But very important are smoking cessation, rehabilitation, and other measures which are like shielding these patients, particularly from not only the atmospheric pollution, but also from the infections. When we look at the therapies to reduce the mortality in COPD patients, then LABA-LAMA ICS is the most important one, which has shown to reduce the mortality in patients of COPD. So triple therapy, and then comes to smoking cessation, pulmonary rehabilitation, long-term oxygen therapy when they are candidates for long-term oxygen, as well as NIV when they are candidates for NIV, and certain patients with who are the candidates for lung volume reduction surgery. That also reduces the long-term mortality in this group of patients. So remember that non-pharmacological therapies have a lot more to give to improve the survival of COPD patients vis-a-vis pharmacotherapy, because we have only LABA-LAMA ICS, and it is the ICS which has been shown to reduce the mortality. So then comes to the last part of my presentation, acute flares, which are called exacerbations. So once the patient comes with acute worsening, our job is not only to diagnose and assess, but also to see to it that they get appropriate treatment to decrease their risk of in-hospital mortality or a future risk of early death in patients of COPD. So it requires a clinical assessment of evidence of COPD and the respiratory and other non-respiratory conditions which can actually worsen the symptoms. And we need to keep in mind always, this patient may be not only COPD acute exacerbation, but might be having underlying pneumonia, might be having underlying cardiovascular condition like heart failure, as well as pulmonary embolism. So we assess their symptoms as well as the signs, and in the signs, very important signs are tachypnea, tachycardia, and hypoxia, and of course the respiratory distress which we can clearly see. Some investigations are of use. Pulse oximetry is one of them. We all understand that. But very importantly, blood eosinophil, CRP levels, and some kind of studies to look at whether it is infective exacerbations by doing tests for viral or bacterial identifications. And of course, arterial blood gases for looking at the carbon dioxide levels, because these will be the patients who, if it is raised, candidates for the NIV. Evaluating other conditions which can mimic exacerbation is very important, because patients with cardiovascular disorders, coronary artery disease, cardiac dysfunction is a very important symptom, a very important disease which leads to similar symptom of increased breathlessness in patients with COPD and may be misdiagnosed as COPD exacerbation. And depending upon how severe is the exacerbation, you really need to divide these patients, whether they go home or they go into the ICUs or they get admitted into the floors like the wards. Coming to, in the suspected patient of COPD acute exacerbation, we need to actually do their severity assessment, mild, moderate, severe. And this will be broadly done on the basis of how symptomatic they are, what are their resting vitals, what are their blood tests particularly related to CRP, as well as ABG showing the carbon dioxide retention, which is the most important thing, or also decrease in the PO2 levels. So ABG, the CRP, the vitals of the patient, as well as the symptoms of the patients are the main criteria to see whether the patient is mild, moderate, or severe exacerbation. Most of the times it is done by eyeballing. We look at the patient, how sick the patient is, but sometimes the patients who do not look so sick may be actually severe patients of acute exacerbation of COPD, and hence blood gases are of immense importance in this group of patients. But the things which we need to rule out is an acute viral or bacterial bronchitis, heart failure, myocardial infarction, cardiac arrhythmias, as well as pulmonary embolism. Pneumonia can be easily picked up on a chest X-ray or a lung ultrasound or a CT scan, and will demand to be looked and need to have a microbiological assessment for viral and bacterial causes for it. Very important to rule out pneumothorax. Chest X-ray is generally good enough, but small pneumothorax can easily be missed, and sometimes we use ultrasound or chest CT scan. In fact, in the last module, which was on imaging, I think all these things were discussed in detail. So once we have confirmed the exacerbation, we decide whether this patient can go home, or patient needs to be hospitalized, or the patient is going to be in the intensive care unit. What we treat them with is bronchodilators. We increase not only the dosages of short-acting bronchodilators, but we combine them with beta-2 agonists, anticholinergics, and even start with long-acting bronchodilators when they become little stable. We try to give it through the devices which easily deliver the drugs, where nebulizers are generally considered as the one which are of choice to deliver the drug for sure to the lungs. But if we don't have, even the spacers with PMDIs are good enough. Oral steroids are generally given to all the patients, but these days we are trying to actually phenoendotype exacerbations also, and the infective exacerbations get anti-infectives, and the allergic and eosinophilic ones get the corticosteroids. So antibiotics generally are considered as for all patients of COPD acute exacerbations, but now more so being given when you have purulent secretions, or you have a positive sputum bacteria, or patients are very sick requiring invasive and non-invasive ventilation. Recently, we have started using HFNC also, as well as NIV, when the patients require a support to wash out the carbon dioxide and improve their oxygenation. So generally in these patients, pulse oximetries are maintained, but yes, of course, you need to do blood gases to look at the CO2 as well as the pH of the patients. But very important, we need to hydrate these patients, and if they are in the ICU and going to be on the bed, then obviously a low molecular weight heparin or subcutaneous heparin is to be given for thromboembolism prophylaxis. All underlying conditions like heart failure, arrhythmias, and pulmonary embolism needs to be treated. These patients after discharge need to be followed up, and within 4 to 4 weeks is the most important thing. Reason being, most common recurrent exacerbations of these patients happen in first 30 days, and that carries a high risk of admissions and high risk of mortality. And thereafter, we need to follow them every 3 to 4 months. And we at that time we also try to review their inhalers as well as all other non-pharmacological therapies which needs to be very much on the on the table for this group of patients, because these patients are the ones who are likely to have exacerbations for the next 2 years. They need to be very closely monitored, and everything on the armamentarium which we can offer them, we should give them to prevent next exacerbation, because if this was not fatal, the next one can be fatal. And at the end, I would say just keep all comorbidities in mind. COPD patients, when they come to us with acute exacerbations and get admitted in the hospital, they have a lot of issues. And there are like these clusters, mental cluster. We have depression, anxiety, cognitive impairment. Respiratory cluster is very important now because OSA, overlap asthma, underlying lung cancer, or associated interstitial lung disease, and very important bronchiectasis can be the reason for recurrent exacerbations and would dictate the treatment of the disease which is associated with it. We may have other diseases like osteoporosis, renal failure, and anemia. All of them will be contributing to not only anemia, but also significant issues can come up if these patients fall down and they develop fractures. Metabolic diseases like diabetes, fatty liver, obesity, reflux disease are also important, but not to forget ever cardiovascular cluster, hypertension, heart failure, cardiac arrhythmias, coronary artery disease, and pulmonary hypertension. All of these can be worsening these patients and need to be tackled accordingly. With that, I would like to thank you all, and we are all open to questions.
Thank you so much, sir, for your insight on the management of COPD, both stable and exacerbation states. And it's very important, as sir said, certain things which we miss out on, how the patient is taking the inhaler, what is the device which is suitable. It should not be just written on the wake of the, pen wants to write it. It should be carefully evaluated, and it gives an important it's an important skill, important point in managing the patients. I would also request the students to please scan the QR code as our quiz master is ready for the quiz. And as it was told earlier itself that you will be getting good prizes on that. Shall we take some questions, sir, before we start the quiz?
Yeah, sure. I think just quickly, because
Yeah.
we have again actually, although we are much better than last episode, but
Last time,
still
yeah.
we thought we'll finish at 4:30, so I'm sure
Right.
we'll be able to maintain that.
Sure.
So take the
So,
good questions. All the
good
questions are good actually. Basically, every
yeah.
question is good question.
So, Dr. Pranav, it is for you. What is the recommendation for air purifiers in the context of COPD and air pollution? Does it really help?
At present, we do not have any recommendations, at least in India and abroad. The reason is we do not have any large-scale studies. My suggestion is air purifiers only work in the appropriate atmosphere with their end, so they should be large and appropriate to the room. The room should be closed. Particularly helpful for children and elderly who will stay near to the air purifier. So if like we take it for ourselves, just reducing exposure for a few hours, I really don't think that is that much practical, and we do not have any evidence on that also.
Right. And do we have any serum biomarkers for the differentiation of phenotypes of COPD? If not, then why is it difficult to identify any highly specific biomarker?
So that's a good question. At present, the only biomarkers we use are eosinophils. So probably for COPD-A and even for exacerbations, they've used eosinophil as a marker to determine the dose and duration of steroids. Other than that, clinically, we are not using any biomarker. But I think, ma'am, history can really help you there. So post-TB, OAD, and maybe for pollution-related COPD can easily be diagnosed with the help of a good history.
Right. Sir, to you, is there a particular ICS which is better in COPD, and which device to choose for COPD? I think sir has given good enough talk on how to choose the device for COPD. So, sir, we'll talk about what is any particular ICS which is better in COPD.
Sir,
Mute, sir. You are muted, sir.
So I think beautifully you said there is no one device which is good for all. So that's not the question at all. So asking about the inhaled corticosteroid, because of the the data showing that fluticasone, which was previously shown to have an increased risk of pneumonia, people have been pushing more towards budesonide, and the newer fluticasone, which is like fluticasone furoate, which has got less potential to have a high ICS potency in the lungs to make it more prone to develop pneumonias. However, I suppose that the guidelines which are now telling us when to use ICS is so specific, where it is the risk of pneumonia or risk or any harm done to the patient is much less in comparison to the benefit which is coming out, because benefit is not only in the term of reduction of next exacerbations but also of mortality benefits. So I think now it completely overweighs that if you decide the right candidate, then it is perfectly fine, whichever ICS you use.
And do you feel, sir, as a developing country, if we can come down on carbon emission by using DPI instead of PMDIs?
Correct. I think we already have a lot of issues related to pollution and the green effect which is required. So I'm sure that it will be good to use the DPIs. Only thing to remember is that every DPI is not the same, and very importantly, you have to see that the patient is able to generate good inspiratory flow rates, because we don't check in our clinics the inspiratory flow rate of the patient. So he should be able to generate that.
But that as it has, because earlier we used to have those CFCs, MDIs, which is now actually almost phased out. We have HFAs, so probably we are depleting little less of ozone
Correct.
layer. But
Correct.
also, what is important is how we dispose those canisters and all, because that is a big thing. And this question, even I wanted to ask when someone has asked. The triple drug formulation in the Respule form for nebulization has come. Do you feel as they are better than the other we used to have, the ICS LABA plus LAMA nebulized formulations, the triple drug versus two drug versus single drug?
I think this question should be asked to Pranav also. I think he will give a different perspective to it, because according to me, yes, it is good in a way that it is costing less rather than, when you have to buy all two of them separately. Second is that it has just been introduced into the market. So we do not have a great idea about how effective it is. But if there is no interaction between the drugs and it takes less time and it's less expensive, then I think that is the basic tenet of having it together. But ultimately, how much benefited one person is very difficult to comment, because in COPD patients, you can't check the PFR of the patient and say that, oh, it has not increased, means it's not good. So it's ultimately, I think, the patient who will be able to tell us that how much effective it is, and that is the most important thing.
I agree, sir.
Pranav, Kanishka, yeah.
Most likely in home maintenance nebulization patients who are already on triple therapy, it can be a good substitute, being probably cheaper and faster. But in emergency situations, I think we should not blindly use it, because then otherwise all nebulization will be just replaced by this and people will probably stop thinking what they are actually giving.
Kanishka, you have to say anything on that?
Well, I think it's too early to compare all those things together. With It's just a recent thing, and I agree with both of Dr. Deepak Talwar sir and Dr. Pranav that it will take some time for you to understand, and we shouldn't be blindly following the triple therapy. And of course, if that confidence is not there yet, then of course it's not wise to comment right now.
Okay, and I think I'll take the last question, which is important as well. So, patients of COPD who are admitted but mobile, since COPD is considered as a systemic inflammatory disorder, which could be prothrombotic state, should we keep anticoagulation in the treatment for the patients who are admitted but are still mobile?
I don't think there are any guidelines for this. We basically use it for ICU. In patients who are immobile, we should ideally use mechanical plus pharmacological thromboprophylaxis. For mobile patients admitted in ward, practically, I don't think they'll be that mobile. So if the patient is bedbound, definitely prophylactic therapy can help. But if we are managing patient ambulatory in probably OPD daycare setting, we wouldn't do this.
So, at our place, if the patient is admitted beyond 3 days. As you rightly said, when they are in the hospital setting, they are not that much mobile. So beyond 3 days, we consider adding prophylaxis for them. So I think we will, last question is a decrease in flow rate of PMDI in high atmospheric zones. I'm not sure about this one, sir. high atmospheric zone, they're talking about hill
High
areas, or
altitude.
high
High altitude.
altitude, whether it
High altitude.
decreases.
High altitude.
I
Okay.
personally feel the inhalers have a flow rate more than 100 km per hour. So that is good enough to fill to the airway with the spacer. And I don't feel that should be an issue at high.
Actually, you
Sure.
need to decrease the flow rate so that it doesn't hit your throat. So if it is little less, it won't make any difference. Only question is it is not going to be more. That is the only thing, I suppose.
So we are done with the questions which were put up in the chat box. I just want to hand over to our quiz master, Dr. Deepak Prajapat, Senior Consultant at MCRD Noida. Over to you, Deepak.
Thank you, ma'am. So I request all the participants. So Sapna, can we have a?
Yeah. So
So I think all our three faculties today, they make our job little easy by giving a beautiful explanation, and most of the questions they already answered. So those who attended all these three talks, they will be able to answer most of the questions. So can
I
we display
yes, so we'll
again, or
start.
I will? Yeah,
I hope everyone has logged in using the QR code. So we'll start, sir.
yeah, sure.
Yeah. So, sir, our first question is
Yeah.
now live.
Our first question is, which is not a COPD ETO type as per the goal 2026. And Dr. Pranav already mentioned in his talk all about the ETO types. So the options are COPD-C, COPD-B, COPD-G, and COPD-D. So I am seeing that the most of the participants, they are giving their responses.
So, sir, we'll move on to the next question.
Yeah. So the second question is, in the context of lung heart axis highlighted in goal 2026, what is the significance of the prothrombotic state immediately following a COPD exacerbation? So what it means, after COPD exacerbation, the all statement whatever are given is true about the regarding the cardiovascular complications. So our first option is, it is primarily driven by hypercapnic induced platelet aggregation. The risk of second option is, the risk of myocardial infarction is increased twofolds for up to 90 days post exacerbation. Third option is, it warrants the routine use of therapeutic anticoagulation in all group E patients. And the fourth option is, the risk of stroke is significantly higher in the first 30 days following a moderate exacerbation. And Dr. Deepak Talwar already mentioned this in his talk. So those who listen his talk, they must be able to answer correctly.
Yes, sir. So we'll move to the next question, sir. Question 3.
The third question is, which of the following defines a significant bronchodilator response in 2026 guideline, and what is its clinical utility in COPD management? First option is, it is more than 12% and more than 200 ml increase in FEV1. It identifies the patient who should be on ICS monotherapy. The second option is, it is more than 12% and more than 200 ml and increase in FEV1, and it does not reliably predict the long-term response to the maintenance therapy. Third option is more than 15% increase in FVC only, and it confirms a diagnosis of asthma COPD overlap. Last option is any increase in FE1 over 100 ml. It mandates the use of SABA only. So Dr. Talwar already discussed this also. So now moving to the fourth question. When assessing the slow vital capacity versus forced vital capacity in a patient with severe emphysema, which of the following spirometric phenomena is expected? So first option is, FVC will be slightly larger than SVC. The SVC will be larger than FVC due to a dynamic airway collapse. The third option is both will be identical if the patient is properly coached. And the fourth option is the difference between the SVC and FVC is used to calculate the diffusion capacity.
So we'll move to the fifth question now.
The fifth question is, as per ERS ATS guideline, which recommends a specific threshold for procalcitonin guided antibiotic therapy in acute exacerbation of COPD. So what is the level of PCT at which antibiotic is started is strongly recommended? So options are more than 0.5, more than 0.1, more than 0.25, and more than 1.
So we are moving to the sixth question, which is now live.
Our next question is, as per Goal 2026, what is the criteria to define Group E in COPD? So our options are, with history of one or more severe exacerbation require hospitalization is last 1 year, with history of 2 or more ER visit in last 1 year, with history of 1 or more moderate to severe exacerbation in last 1 year, and with history of no exacerbation in last 1 year. So this question was discussed by Dr. Talwar as well as our other colleagues.
We are now at question 7, sir.
So the seventh question is, Gold update discusses the use of HFNC high flow nasal cannula in acute exacerbation of COPD. What is the primary physiological benefit of HFNC over standard oxygen in hypercapnic patients? So options are, it provides fixed FiO2 of 100%. It creates a dead space washout effect in upper airway and reducing the PCO2. It provides PEEP level equivalent to 15 centimeter CO2, and it prevents the need for any bronchodilator therapy.
Okay, sir. So we are moving to question number.
Next question. So which of the following statement is false regarding the vaccination in COPD as per Goal 26? And our options are, can you move the slide little up? I'm not able to see the option. Yeah. So first option is influenza vaccine in all COPD. Second option is RSV vaccine in COPD with more than 50 years of age. Third option is zoster vaccine in all COPD patients. And the last option is PCV20 vaccine in all COPD. So please read carefully and give the answer. So which is false statement? Move to the next question.
So, question 9, yeah, it's
So
9.
about the intervention, which intervention treatment is proposed in patient of COPD with chronic bronchitis phenotype as per Goal 26? And the options are, first option is use of coils. Second option is targeted lung denervation. Third option is nitrogen cryospray. And the fourth option is thermal vapor ablation. So in the intervention treatment for chronic bronchitis phenotype in COPD, what is the appropriate treatment? So last question is, in the context of triple therapy mortality data by ETHOS and IMPACT trial, which component out of 3 bronchodilators which we are using, which component is believed to be responsible for the mortality benefit? LAMA, LABA, ICS, or there is a synergy between all 3? So I again repeat that which component is believed to be responsible for mortality benefit?
So we are done with the.
So I think we have done. So we have recorded all the answers.
We'll need 2 minutes to get the top 3 winners, sir.
Okay, so in the meantime, I'll discuss the explanation for all the answers. So can you stop sharing? Yeah. So our first question was, which is not COPD etiotype as per goal 2026. So as Dr. Pranav already mentioned in his talk, the COPD B is the one which is not mentioned in the list. Rest all COPD C is a cigarette smokers, the G is genetically, and the D is developmental. Then the next question is, in context of lung heart axis, in the goal 26, the significance of prothrombotic state immediately following COPD exacerbation. And the answer is, the goal places heavy emphasis on the fact that even moderate exacerbation trigger a systemic inflammation that peaks the cardiovascular risk, including stroke as well as myocardial infarction in the first 30 days, not 90 days. Then the next question is, which of the following defines a significant bronchodilator response in 26 guidelines, and what is the clinical utility in COPD management? So while the threshold remains same, the more than 12% and more than 200 ml, the goal 26 clarifies that a positive reversibility test does not help differentiate between COPD from asthma perfectly, and nor does it predict which patient will respond best to the long-term LABA and LABA therapy. So the option B is correct. So the fifth question was, when assessing the slow vital capacity versus forced vital capacity in a patient with severe emphysema, which of the following spirometric phenomena is expected? And the answer is, in severe COPD, forced expiration generate high pleural pressures that causes the dynamic compression of the poorly supported airways, and a slow maneuver prevents this collapse and often resulting in a large SVC and a more accurate reflection of true gas trapping. So the SVC is always larger than the FVC in such dynamic airway collapse. The next question was, ERS ATS guidelines, they recommend a specific threshold for PCT to start the antibiotic, which is strongly encouraged, is more than 0.5. The next question was, as per COPD goal 26, what is the criteria to define group E in the COPD? And as per the algorithm, the group E is defined as one or more moderate or severe exacerbation in the previous year. No hospitalization is there, and only one moderate to severe exacerbation is required. So that's why option C is the correct answer. The next question was, the gold update discusses about the use of HFNC. So what is the physiological benefit which HFNC is given over the oxygen therapy? So it basically creates a dead space washout effect in the upper airways and reducing the PCO2. However, it also provides the PEEP levels, but the PEEP levels are not equivalent to 15 centimeter of mercury. It will reach up to the 8 to 10 level, not beyond that. Then the question is, which of the following statement is false regarding the vaccination in COPD? So the right answer among all, the false statement is the third one, that the zoster vaccine is given to all patients. However, the zoster vaccine to prevent against shingles for people with COPD aged more than 50 years, not in all the patients. Then the question was on intervention treatment about the chronic bronchitis. So in chronic bronchitis, the nitrogen cryospray is recommended. The last one, in context of triple therapy mortality data, which component is believed to be responsible for mortality benefits? The correct answer is the ICS component, because during the trial, they compared the glycopyrronium and the formoterol combination with the budesonide glycopyrronium and the formoterol combination, and they saw that the mortality benefit is in the triple combination which they are using, and they concluded that the ICS is the main component which is responsible for the anti-inflammatory effect over the vascular areas in the COPD patients. So that's why the cardiovascular mortality is less in the group who receive the inhaled corticosteroid in the triple combination. So thank you so much. I think we discussed all the questions. So ma'am, all to you.
Thank you,
Richa,
Deepak.
1 minute. 1 minute,
Yes,
Richa.
sir.
They
Yes,
are
sir.
they want the results to be announced for today's quiz also. They
Yeah.
are very excited actually because I can see that a lot of postgraduates are now looking forward to that who's answered the best. So three winners: Dr. Tapas Ranjan Behra, Dr. Hari Kishan R, and Dr. Saurav Kumar Giri. I think for somebody from the center has come, so I can see that MES Medical College is already thumping. So somebody has got the prize from there. Good. So we have three prizes. First prize is 1,000, sorry, 10,000 Amazon rupees vouchers, then 7,500 second, and 5,000 Amazon vouchers for the third one. All the best and congratulations to the winners. Keep trying, and keep getting more and more. But yes, we will be along with that having 10 students. Again, the list will be declared in the next one: 10 from the first episode, 10 from the second episode, who will have all hospitality in PAX 2026 from PAX. So that's another prize which is going to be there for 10 most promising postgraduates of each episode.
So congratulations to all.
Congratulations to all. Yes, true. So over to you, Richa.
Congratulations, a very, very big congratulations for the winners of today's quiz. And as Sir said, there is much more exciting things which are coming up, not just the prize. I think it is a learning process, and that is what PAX has actually put up the things together. So there is a constant interaction between the RPGs and our faculty. So we would like to encourage you more and more to ask more questions, more difficult questions to us. And then not only will you gain the knowledge, but you will also clear your doubts as well as you will receive the prize. So with this, I would like to end up this today's module on obstructive airway disease, COPD. Uh, Nothing would have been possible if our academic partners, Alchem, would have not been there. So, on behalf of PAX and all the faculty, we would like to thank Alchem, our academic partner, who have made this possible to bring up the PG Connect program. Swapna and technical team, thank you so much. All the speakers, Deepak sir, Kanishk, and Pranav, thank you so much for your insightful lectures. I'm sure the PGs would have got too much, the entire gold guidelines in a period of just 1 hour and 30 minutes. And of course, Deepak Prajapat being so asking difficult questions for the quiz, but they were not actually. If
So
if
Richa, there is one more thing that we sent a case study for the discussion in which the HODs can themselves discuss with their students as to
right,
how to apply it into their practice by a case, a real life case in which how the things have happened. So that case
right.
study, Sapna will please share with all the HODs. They can discuss at their leisure time whenever they have time. They can discuss with their postgraduates
Yes.
and keep giving us the feedbacks. We tried to incorporate a lot of changes which were required from the last episode. We have done definitely better than the last episode. Last episode went up to 6 p.m. actually, and today it's 4:45. We'll try to do it even better next time.
Sure. So with that, thank you everyone, and we look forward for the third module, which is coming next month and on first Wednesday. There might be a change in the date, if at all, because a festival is falling on that day, but we will keep tuned for the announcement. Thank you everyone. Thank you so much.
Thank you.
Thank you. Thank you, sir. Thank you, ma'am. Thank you, Pranav, sir.